recording.
Hello, everybody, and welcome. My name is Ann Henshaw, and Chris and I are very excited to be continuing our efforts with the American Palliative Rehabilitation Alliance and bringing a multidisciplinary team together to meet the needs of seriously ill patients and their families. Tonight, we are so excited to have some guests here from UNC. So let me introduce first Michelle LeBlanc, a physical therapist at UNC Medical Center with a focus on oncology. She graduated from East Carolina University and has a doctorate in physical therapy. She previously worked as an investigator on the Stamina study through the UNC Chapel Hill and Duke University group, focusing on nurse-led interventions. Let's see, exercise program to improve patient-reported outcomes in adults in adults with acute leukemia. And she's currently an investigator and co-developer of the physical therapy protocol for the Palliative and Collaborative Care Team, the PACT, which I think we'll hear about tonight. And she's presented this research at APTA and other places. So we're delighted to have you, Michelle. Welcome.
Thank you.
And also Alexis Petaway, an occupational therapist, also at UNC Medical Center. She graduated from UNC Chapel Hill, and she has spent her career working in acute care with a primary focus on oncology. She's completed specialized courses and foundations of oncology and breast cancer rehab. And she's currently an investigator for the PACT, the thing I think the same together that we're going to learn more about
yes,
today.
it is.
And she has, which has allowed her to continue to advocate and address the intersection of quality of life and function. I love that. That was my favorite line, because that's really what we all do, right? So welcome, yes. And we are so delighted to have you. Chris, did you want to launch a little bit first on website stuff, or are we going to jump right in? Oh, he's ahead of me per usual.
There you go. I was muted. I was trying to make sure that I was kind of keeping background.
Chris is the tech support behind, the tech genius behind this, and Jordan.
So a few logistics about the webinar. Everyone will be muted and have their cameras off, but there is an opportunity for Q&A. So down at the bottom, there is a Q&A button. If you have questions that you want to kind of get answered, or you just have comments or thoughts, you can put them in the Q&A, and then at the end, Michelle and Alexis will try and answer some of those if they don't answer them already during your presentation. So you are viewing your American Palliative Care Alliance, or American Palliative Rehabilitation Alliance, which is palliative rehab. So you just go to palliativerehab.com and it will take you right there. So right now we have this upcoming webinar, but we have tons of resources. We have upcoming events and past events. A little bit on education, international resources. We've got all kinds of journal articles and books, who's kind of on the team here, and then for healthcare providers. So I do want to point out the past events and recordings. We just posted a few really interesting webinars. We had a very well attended American Physical Therapy Association webinar. I think almost 300 people attended it through the APTA oncology and acute care, really kind of talking about the ethics of acute care and palliative care PT. And then we also recently had a really enriching discussion with Joanne Biley, who was from the UK and actually was the author of the World Health Organization's position paper on palliative rehabilitation. So if you're not aware of that, that is really amazing. So those are kind of our newest ones, and we do have some kind of past recordings on rehab and OT, difficult conversations, and then Zimbabwe physical therapy and kind of integrating palliative rehabilitation in that. So enough about me and enough about our website. I'm happy to pass it off to Michelle and Alexis. So take it away.
Wow, thank you so much. Okay, we're Michelle's sharing our screen here. Okay, so we are very excited that you're joining us this evening. Okay.
That was the wrong screen here.
There we go. All right. Now, we are also excited to have the opportunity to share and describe the transformative process that we are still involved in to this day, and talk about this team-based approach that I think all the settings need, but none of them have so far. So tonight we want to talk about, let's see, how do we go to, oh, there we go. We want to describe this process, like what is PACT and what is the PACT team, and specifically in the context of older adults with leukemia. We want to understand how this process came about, and also just talk a little bit about the outcome measures that we were using, the strengths, the areas of improvement, and kind of where we go from here. So PACT, it's a little bit of a different acronym, but it stands for Palliative and Collaborative Care Intervention. And so the primary investigator, Dr. Ashley Bryant, she kind of like led us into this notion that there is a huge gap in research, especially as it pertains to older adults with acute myeloid leukemia, so AML. And so a lot of these new treatment regimens are evolving, and they're progressing to more of an outpatient based versus like an inpatient based delivery model. And so a lot of like multifaceted functional concerns have emerged in different settings. So patients are no longer, seeing or needing help on the inpatient route, but they're at home, they're in the community, they're in the clinics, and they're having these functional deficits that really there's not a lot of people who are coming to address them. So the PACT team aims to have specialists from various disciplines focus on symptom management, the prevention of functional decline, and hopefully all of this will contribute to an increased quality of life. Previous studies have not utilize this interdisciplinary approach. So the PACT study is pretty much kind of revolutionary, especially as it comes to AML and the chemo regimens that we're discovering and we're part of. So the PACT team is, I think kind of unique. OT and PT are always seem like we're siblings, yeah. I think. But the primary team also involves a nurse. And so the primary role of the nurse is symptom management and tracking, which I think sometimes we like to work on function and quality of life, but that symptom management and tracking is really important, especially as it pertains to older adults and older adults with leukemia. So the RN is in charge of that. The OT is going to assist with identifying and intervening on participation and meaningful activities. So like, what are the things that are important? How can we increase participation or maintain participation throughout the chemo regimen and throughout just the life course in general? And then the PT is going to assist with enhancing those capacities or skills that the participant needs to be able to do the things that they want and need to. The most important aspect of this team, though, and I think it's an important aspect of any palliative care team, is that we are going to keep the client and their care partner at the center of the team. So they're always going to be involved and guide and influence how, when, and why we are intervening. So I think that's the most important thing. The client and their care partner are kind of sitting there in the meetings with us. They're there talking with us. They're an integral part of the team. We honestly should have included them as part of the primary team.
And I think that's one of the most unique parts about the PACT study is the care partner is also like consented, and they are part of the study just as the same as the participant and the patient themselves. So we have specific outcome measures that they fill out themselves. So we're really looking at that dyad as well.
Exactly. Okay. Oh, sorry. This is
so some of the training that we all did, we like nursing, PT, OT, palliative care physicians, we all met together over the course of multiple days. And one of the major frameworks that we're using is this adaptive leadership framework. So one of the nurses, Dr. Ruth Anderson, gave a lovely presentation, and it was a lot about how we want the patient and their care partner to become leaders in their care and how to advocate for themselves, and how we can help close that gap and make that part of their regular routines. We also, Dr. Laura Hansen is one of our palliative care physicians, and so she gave a presentation about quality care for cancer and her perspective and her role that she's seen. She's got so much experience. I don't want to age her, but decades of experience in this arena. And so her insight was very valuable. And then Dr. Ashley Bryant, who's the primary investigator, she's done multiple studies in the past with adults with acute myeloid leukemia. So we got to hear her perspective and really the big gaps that she's seen in their care. The pharmacist, we also learned a lot about the chemo regimen that these patients are on. So it's azacitidine and venetoclax. Azacitidine can be either like an injection or an infusion, typically an injection every day for 7 days. And then venetoclax is an oral chemo pill that the patients can take at home for the next 3 weeks. So it's a month-long chemotherapy regimen with an entire week that patients have to come into the hospital clinic daily for that first week. And then as part of our training, we're also always thinking about what's next. So then what's the biggest part? Because this is like a preliminary and study. Like we're just looking and see where we need to be, where we need to fill those gaps, what gaps do we not even know about yet. So we have a sister hospital, Rex, who has a cancer center. And so we're also looking to expand there because a lot of our patients also get care there because it's smaller, it's a little bit more accessible than the main hospital. So we all went through all this training. And then we had this really unique opportunity and unique challenge of developing a protocol. Dr. Ashley Bryant she respects every discipline and all of their insight and perspectives, which is amazing and a unique opportunity, but it was also very different for us as acute care therapists to be developing a research protocol. So as a team, our main goals were to find standardized assessments that were going to address the key issues that we've noticed in our practice and that we've found from literature. And we also wanted to create a protocol that wasn't just standardized assessments. We really wanted to have a flexible component that we could go off script. We could address what the patient and their care partner really find important to them. So when we were looking for literature, there's not much out there, as a lot of you probably know, in patients who are getting active cancer treatment, but specifically in older adults with AML. So we had to pull from a lot of different resources, a lot of our practical experience and clinical experience was so valuable. We have not a huge team, but lots of years of practice between everyone in oncology care. And then we're always learning from our clients and their care partners. That is the most important part of our protocol. That flexibility piece, we can adapt based on what their feedback and what their needs are. So for the PTs, we wanted to consider which outcome measures we wanted to do. There's so many outcome measures. There are very few that have any standardization in the oncology realm. So some things we wanted to take into consideration, their time. When we're scheduling patients to see them, we're fitting ourselves in their current clinic schedule. So they come to our hospital for their labs, infusions, transfusions, and doctor's appointments. And we're not trying to be an extra burden on their busy schedule. So we are trying to fit in something time efficient. We want tests that are sensitive to the changes that we anticipate they'll experience. And then the different domains that they will probably experience changes in. So balance, endurance, strength, fatigue, quality of life. We want to hit as many as we can. So what we ended up with were the Berg balance, 6-minute walk, time to and go. And then the AMPAC I'll go through in a little bit, but it can be either patient reported or performance-based. All of the others are performance-based outcome measures. So we have a few here. So just a really brief overview of the Berg for anyone who might not be familiar, but it's a lot of different functional balance assessments squished into one test. And I love it because it is really time efficient. We can do this in a small space We can do it with not a lot of time, and we can get a good picture of different areas for improvement. The AMPAC, so that's the activity measure for post-acute care. It's a very easy, quick test to do. Don't even have to actually see them do anything. They can report it themselves, which has its own pros and cons, but it's very basic mobility screening, bed mobility, transfers, stairs, ambulation, and how much assistance they require. And then when we were developing our intervention, we want to take all of the data from the outcome measures, the interview with the patient and their care partner, and then kind of find what's most important to intervene on. So we want to do a lot of education. We ended up creating a binder that we give to every participant and their care partner with lots of education, including like nursing care about their chemo, infection control, PT, like our education on energy conservation, activity pacing, and then all of their HEP. So HEP for PT, we want to include a walking program because that's the most accessible for these patients. It doesn't require any equipment, doesn't require much space, and it can be varied based on their fatigue and energy levels. We also created standardized exercise handouts. So we wanted to use these measures and find something semi-standardized to give them exercises so that we're not just creating new exercises. Each PT that sees them isn't giving them a different version of the same exercise. So we created different levels. We use if they scored X number on the Berg and X number on the 30-second sit to stand, it puts them into a category for different levels of exercises. And then exercise prescriptions for patients getting active chemo, there's not much out there either. Even the American College of Rehab, they do not have much active guidance right now. There's a lot of research being done, but there's not much information there yet. So we want to decrease their fatigue levels, which means using some energy, but educating them on that concept. Their appointment burden is very high. So we want to create things that they can do in short bouts that are very easy, and then change their perception of exercise. It doesn't mean that they're going to be going to lifting weights. Like going for a walk is their exercise. Coming in, we have a large hospital, coming in from the parking deck can be exercise for them. So really reframing that and setting them up for success. So here is an example of a home exercise program for one of our participants. We have the level here. So they were level 1. There were 3 different levels. And so some different functional strength things they can do, some squats. Really want to increase their core strength and endurance because that leads to their overall energy levels. And then the walking program, we used formulas from another training we did from the Physiological Oncology Rehab Institute. And they have some great formulas that we can use data from the 6-minute walk test to create heart rate goals and heart rate max, as well as intensity and frequency recommendations. So we provided this as part of their binder, and we got a lot of great feedback initially, but the compliance was a little bit off. I will say there wasn't a whole lot of focus on it. So that's one area for improvement. I think if we could have more real-time like checklists or compliance tracking, I think that would really help. There's a lot more technology available now, and especially outside of a research study, IRB compliance, we could probably do a little bit more there. But some of the biggest strengths, we assessed a lot of different domains. We really hit on balance and endurance, which are the 2 biggest deficits that we see. And our intervention is so flexible. If someone comes in, they've been having trouble with the stairs, well, then let's go talk about the stairs. Let's give you some exercises for that. We aren't stuck in a rigid intervention program. The other biggest strength is including that care partner and caregiver they're part of the education, but they're also part of, like, we encourage them to walk with them or do the exercises with them so that it's not just the patient, they're not separated. They can both get the benefits. And then some other areas for improvement, our clinic space is very small. We don't have dedicated space. And some of the outcome measures, especially the 6-minute walk, is a little bit time restrictive. A lot of patients are trying to get to that next appointment. So the 6-minute walk doesn't always happen. So we're looking into more of like a 2-minute walk to see if it's a little bit more feasible.
And I want to add on to that of note too, as part of the study, participants get a Fitbit. So that I think especially helps with like the walking program and all of that, but we haven't, I don't know if they were using the Fitbit a lot. Like, you know, anecdotally, I think the newer technology was often difficult to integrate into their normal routines. So that was one of the main feedback that at least nursing and, you know, we've gotten from participants. Having to download an app on a phone that they may or may not use regularly. Yeah, we definitely got like, are they tracking me and stuff? So it's, you know, but I think that it shows like how, you know, even the nursing intervention can kind of help even with the PT intervention of the walking program and how many steps are you getting a day and all of that. So the OT protocol development was a lot of the same things. I think the main thing that we ran into was just how much limited research there is, especially with any type of OT programs or protocols with specifically older adults in leukemia. There's really not a lot at all. Thankfully, we had 2 OT consultants who are very versed in the field, so they were so helpful. But we were like, you know, what are we going off of? So we had to pull from a lot of different research. We also wanted to be very variable. So we wanted to, you know, address cognition or brain fog, chemo brain or whatever, fatigue, ADL participation, IADL participation, leisure, psychosocial participation. There's just so many things under the sun. But like, what type of assessment do we do? Because there's not also a lot of performance-based OT assessments. And then too, initially when this study began, we were developing a protocol for more of an inpatient basis because that's what the chemo delivery model was. These people would stay in the hospital for, you know, 3 to 4 weeks while they were getting chemo. So that's kind of how we initially developed our protocol. And then this new AZA-VEN protocol was released and we were like, oh, we're going to be seeing these people in the clinic. So this is going to be more of an outpatient-based protocol. Just, you know, just being real, all of us, at least, you know, all of the clinicians, we were not outpatient therapists. So I think it was a big shift of like, okay, how do we switch this protocol to something that could be used on an outpatient basis, but still flexible enough, like if these people were inpatient, we could use them. So the assessments that we ended up choosing were the modified COPM, and I want to asterisk the modified because it's not the actual COPM, and it gives us the flexibility to change it, to, you know, take ratings in or out, you know, to use it as just pretty much an intervention, or not an intervention, an interview tool. The dynamometer grip strength, the clock draw, and then the 2 aspects of the performance assessment of self-care skills or the PASS are hand hygiene and medication management. And I'll talk a little bit more about each one of those. So for the modified COPM, I like to say that it's modified because not everybody, and I know my OTs here, not everybody is going to do well with the rating. You'll ask them like, okay, rate your performance of this specific occupation on a scale of 0 to 10. And people are like, what are you talking about? So like for this specific person, the performance, the satisfaction, the concerns, this person was not getting that at all. So we had to switch it up and let's just identify some of your goals. And so specifically going to sports games, being able to mow his lawn, those were the main things. The performance satisfaction and concerns really weren't anything important. So the modified COPM really allowed us to be able to use those ratings, not use those ratings, just use it more so as a tool for, you know, talking and identifying those specific meaningful activities. The impact 6 clicks, that's pretty much like Michelle said, it's very general. We use this in acute care. But you know, I think it does provide a simple number that's useful for tracking. Like every single time, boom, you get a number, boom, and you can see up, down, same, all of that. Now the performance assessment of self-care skills, I think this one took the most time to train because it's a little bit intricate in terms of like what we're rating. So with this specific assessment, you can create your own subtask. And so we created the hand hygiene subtask to pretty much replicate like a basic ADL or a standing ADL. And then we have the medication management subtasks as well. So we have them perform both. And I do like the PASS because it, first of all, it's performance-based, which is rare, I think, for OT assessments. And it allows us to identify different tasks and score the patient on independence, safety, and the quality of tasks. So this allowed us to create more like, you know, ADL-like tasks or more cognitive tasks, which I think was helpful. And especially coming from like an inpatient basis, it allowed us to have something to, you know, like do and have the client do something.
And I think it brought up a lot of different variables between the patient and their care partner too.
Yes, exactly.
A lot of like, oh, my care partner is the one who does the medications, but sometimes they don't, or sometimes they weren't doing it right either.
Exactly.
So a lot of different dynamics at play.
And it allowed us to say, okay, if your care partner's doing it, like, let's have your care partner do the PASS, and then they don't do it well, and we're like, ooh, okay, let's talk about, because everybody's getting it wrong in the household. But it does create some good insight, and maybe, you know, they're independent in it, but their safety is not good, or the quality of task is not good. So it allows us to see a little bit more about like, where does this task break down? And something that like OTs are so good at, the activity analysis, it gives us a chance to just, you know, witness that firsthand. The clock draw test, we, I think this was really helpful. It was another tool that allowed us to track, you know, more so the executive functioning. But what I found most valuable about the clock draw was not necessarily the score, but just like witnessing and observing them do the clock draw, because that provided insight into their sequencing, their visual motor processing, their coordination, like a lot of different things that, you know, we wouldn't necessarily be able to see. And it's something that we could, you know, do in the clinic setting. And then finally, the handheld dynamometer, there's the research that is out there. It's a lot of research that connects, for some reason, grip strength and like mortality rate, or grip strength and functional outcomes specifically for the oncology population. So we thought it was important to include this as just some like empirical evidence, or just, you know, specific numbers that we could track changes with. It's not the most functional thing, you know, from an OT perspective, but it I think still provides some good information. And anecdotally, I think people got excited about grip strength for whatever reason. You know, they were really excited about the grip strength. They get exactly.
I think I found the same thing with the sit 30 seconds in the stands. Sometimes you had to remind people, like, you know, you really do have to sit down.
Exactly. And what I think, you know, just, I might be jumping ahead, but what we found mostly was there was not a lot of changes in the grip string, but, you know, the biggest lesson was, are people staying the same? Which generally they are pretty consistent throughout the process until they get to like end of life. So our intervention was very broad. We had education, ADL, IADL retraining. We had a exercise program, but we didn't necessarily provide that a lot. Our main focus was more so this home occupations program where we were providing specific activities that would kind of maybe satisfy an exercise program or an activity level that the client and care partner were seeking. We also had activity modification and cognitive training, retraining. I guess because of the nature of the clinic environment, like we were in the infusion clinic in this small room, like specific occupation training, like ADLs, IADLs was difficult because we were just in a room with like 2 couches and a lamp. Like it was, yeah, that was hard. So I think I would say the primary provision of our intervention was education based for sure. This is an example of one of the OT home exercise programs that we did not provide, but it was there. Like Michelle said, it was in the binder, so we could always say refer to this, and it very much, I think, we were focusing hopefully on like proximal strength and breathing, the diaphragmatic breathing kind of, you could go into guided imagery and more of a like relaxation psychosocial perspective. But I think the utilization of at least the OT exercise program was not a lot. This is how we would document the home occupations program. So what I didn't include up here is we would also provide as part of the walking program an activity log. So people could track, okay, what are some of the activities that I'm just doing during the day? Like even if it's like I'm walking from my car to the infusion clinic, like how does this satisfy the walking program? Or like how can I reframe and see this as activity or exercise that I'm doing just in my daily activities? So that was also part of our intervention binder, and what you see on the screen is kind of how we would maybe document, like how did we talk about their home occupations program, or like did we mention it at all? So as this was a pilot study, we were working from the ground up. And just like, to be frank, we didn't really know what we were doing a lot of times, but there was a lot of learning happening. And I think that at the end of the day, we learned a lot from our clients, from our care partners. Hopefully they got valuable information from us. And I think that we did address a variety of skills like cognition, strength, balance, energy was a big thing. And then we left the space for the clinical reasoning because we all have so much experience and varied experience. We did not want to take that clinical reasoning part out, but we also wanted it to be like generalized. So if this was carried out at another hospital or another clinic location, like could they do these same assessments? We didn't want the assessments to be so specific to UNC that this is something that couldn't be done in other places. And along that line too, like could it be done in various settings? Like I think our intervention, we could do it inpatient, we could do it outpatient, we could do it in the home. Like you can do it, in the grocery store. Like we could do this anywhere. So that allows for some flexibility. Just from our preliminary data, the sensitivity, at least for the OT assessments, is not good. The assessments I think that we chose are not sensitive enough to track the changes that our clients are experiencing. So that's just for future reference. We have to find something that's going to be a bit more sensitive. And then in general too, which is just a broader, I think, OT related barrier, it's not very performance based. There's a lot of education, even in the assessments, there's maybe self-report or interview, but we're not like seeing and witnessing, observing a lot of things, which I think then we lose out on some of that like activity analysis that we're so good at.
And just the research data.
Mhm.
Research is so data qualitative or quantitative based.
Exactly.
But I think the nurses, when they're tracking, they do a lot of the qualitative look back, which I think is a strength of our overall study, because between both of us and the nursing assessments, we get so much qualitative data. So I think that flexibility is great and allows for that. So now the nursing role, they are kind of driving the ship for this study. They interact with the patient and their care partner weekly. So the patient fills out a daily symptom symptom questionnaire, including fatigue, nausea. Are they having any new symptoms? And the nurse can track each day. Oh, they rated nausea as a 10 out of 10. That's new for them. So they'll call them, it'll prompt a call. They'll call the patient. Then the nurse can liaise with the primary team and be like, hey, can we get this patient something to control their nausea? Let's manage those symptoms quickly and not wait for their next appointment. They also provide care partner support. So they're also not only calling the patient, but also calling the care partner every week. And I think that's been so valuable for them to normalize some of their experiences as a caregiver for someone with a terminal disease. Their role changes a lot throughout their treatment. Sometimes they're just there to take them to appointments. Sometimes they're helping with ADLs. And sometimes they have their own medical needs and personal needs. So that's been really eye-opening. And I think my favorite part of the study is that we do have that holistic approach and really can treat the whole dyad. The nurses have so many undocumented roles. They are basically a navigator for all of their care. They are how we can all communicate with the team for additional resources, but they really are taking the most of that. And then the patients and care partners have their contact information, so they can reach out if they have an emergency, a question. They're usually the first person that the patient reaches out to. They're not going to the nurse line for the hospital. They're going to their personal nurse. And I think that personalized care and that rapport and relationship is so valuable, and it just can't be measured. That trust that they have, and they, like, the nurse will let us know, hey, can you give this person a call? They had a fall, or they're having a lot of pain. And then we can also be building that rapport with them. And we, like, over time, we've seen some of these patients for 2 years now. So that relationship is so crucial. And I think the nurse really ties in the whole team. So working together, what it really looks like. We did all the specialized training together. And then when we meet a participant and their care partner, we do what we call an arena assessment. So we all go in together to talk to the participant and their care partner and really get to know them. We're not having to ask all the same questions 3 different times. And I think the patient and care partner really value that interdisciplinary approach, and they really see us, they have the visual of us working as a team, which they don't always get on an outpatient setting. And then once we do our assessments, we do our arena assessment and interviews, we do our discipline specific assessments, and then we do, usually if we can schedule it, we'll do like our intervention, sometimes together, sometimes a little bit separated. And then every week, we used to do twice a week meetings with the whole team. So the nurses, the research assistants,
The consultants.
consultants, PTs, OTs, our primary investigator, we're all sitting down for 30 minutes twice a week and really talking about each one of our participants. We have 18 of them. And so we can really go in, oh, I heard this from them. Well, here's what I can bring. And it's that real-time collaboration. And then we all have dedicated time for it, which is so unique. We're not having to rush off to anywhere else. This is our time. And in the palliative world, that's so important. We're all talking through a quality of life lens. Like, we're not trying to fix all the things in their life. We're
Mhm.
we're trying to see what's important to them and talk about how each of us can address it. And then we also are all learning as we go. I love our team. We're very flexible.
Mhm.
We learn from each other. And we will support each other when we have like patients who aren't doing well or pass away. Um, we can really lean on each other and trust each other, and also reach out to the patient and their care partner.
Mhm.
They also do bereaved care partner interviews. So the study doesn't just go through the end of their life, it goes past that, because we really want the care partner still part of the study.
Mhm.
We want to be supportive of them and their experience, and we learn a lot from them as well. So here are, I put a whole list of assessments. There's a lot on there that the patients fill out, especially with nursing. The nursing ones are all digital, so they're not having to do paper forms. But I do want to point out we do have 2 just care partner assessments. So at the bottom there's a promise and affect and well-being form. And those are just there to assess the care partner's mental health, physical health, their well-being, because they're a huge part of the team,
Mhm.
and their wellness really, really impacts the patient's wellness. There's a lot of different dynamics depending on if they're a spouse, if they're a family, like a child, a friend, if they don't have a care partner at all.
Mhm.
All of those different dynamics are really, really interesting to see.
So with all the benefits that come, there are some challenges that are going to emerge as being part of an interdisciplinary team. I think one of the things was nursing gets so much like good information, especially from their surveys that they're doing with the care partners and the participants, but we didn't really have like real-time access to that information. So sometimes we would be asking about like cognitive changes or like, did you have a fall? And maybe nursing already asked that like 2 weeks ago. And even though we were talking about these things in the meetings, like having access to those surveys was really important. Scheduling was also a big thing, as we as adults all know. For example, Michelle and I both function in our primary roles as acute care therapists. So we maintain a full caseload. We have, a full 9 to 5 productivity standards, all of that. So we were doing this in addition to our full-time roles. So it would be like, okay, we're leaving a patient's room, boom, our participants downstairs in the clinic, like ready to do their assessment. So we would kind of have to run down. So that was a little bit difficult at times. And then you're also working in the context of like, staffing constraints. We always need OTs, PTs, speech. Like nursing is so underrepresented, and they always have, a need for nurses. So we're having to work on, pretty much like understaffed teams. But I think that goes to show the importance of why having management support is so important. So Ashley, our primary investigator, was just such a great advocate for us and has a great relationship with our management and our directors of our department. So like, pretty much anytime we needed on the PAC study, we got it. So that I was very grateful for that. But it was still a little bit difficult of like, okay, we have like a family training at this time, but we have this assessment at this time. Like, what do we prioritize?
And then too, with that, just with it being research, we're trying to get as many standardized assessments in, but patients are trying to run off to this appointment or that appointment because we don't have a scheduling block on their calendar. We're not part of their appointment list. So in future iterations and studies, we want to try to have an actual appointment time so we can really spend more quality and dedicated time with these people.
Yeah.
So we have a couple of case studies just to go through a little bit of what it really looked like for some of the participants. So our first one, Allison, she was an 82-year-old white Hispanic female. Her only pertinent medical history was lumbar radiculopathy, which caused a lot of pain which would come and go, but really impact her functional status. Her care partner was her husband. They had been married for, gosh, like
Oh my
50
goodness,
years,
yeah,
I
50
think.
years, yeah.
And then her baseline functional status, she's Mod-I with a role leader, primarily in the household, had difficulty with stairs, mostly due to her radiculopathy. She was independent with her ADLs, but needed some assistance for her ADLs. So here are just some areas that we're going to talk about that we were able to intervene on. Their psychosocial needs. So this participant, when we saw her a month after she got diagnosed, right when she was starting treatment, she was so overwhelmed by her diagnosis. She was still tearful. She and her husband still hadn't had kind of found a way to tell their children about it. So she was really anxious, overwhelmed, and we were able to help normalize some of those feelings for her and find things that would help manage her anxiety, help bring her some joy in this very not joyous time in her life. And then her functional status was one thing that was limiting her participation in those things that she enjoyed. So she had a craft room upstairs, but because stairs were difficult, she couldn't access those areas. So we really wanted to work on modifying those. If we can bring the crafts downstairs. We also worked on her strength and some like lumbar radiculopathy treatment so that we could help with that, and also giving her some tools and questions to ask her primary team about pain management, other referrals. She hadn't seen an orthopedist in a long time, so we really wanted her to get some other consults in so we could really find the root of the issue. Her care partner was so quiet.
Yeah.
He was a man of very few words, but he was there through thick and thin. The most important things to her was doing laundry. She took a lot of pride in it, and he did not do laundry quite like she liked. So that was always something that impacted their relationship, and it was really nice to see their relationship grow, and it was still growing, even though you're like going towards end of life. That relationship is still changing.
Yeah. And I think he took that role on, as a way to kind of, help her through her various medical needs. But there was a point where she wanted it back, but she didn't know how to say that. So it was interesting to try and navigate okay, just, how do we tell him okay, I want to do the laundry again,
Yeah. And we saw participants at different cycles. So each cycle is 1 month, so different months throughout their treatment. Her medical needs, her first cycle was complicated. She had a really long hospitalization. It was 24 days. Her mental status was very altered. She was agitated. She had a PE, respiratory failure, and was even in the ICU for a little bit. So that was a huge change for her, and that was really the start of their role change. She even had to go to skilled nursing facility for about a week, but then she was she was resilient. She was quite resilient, and I think we were able to help foster that resilience and really help her kind of draw back on that. Because at times she said she felt like a flat tire. So I thought that was a really kind of good visual for people. But the other thing that she loved to do was she collected cookbooks. And so we helped kind of just encourage her to look through her cookbooks, even talk about things that she wanted to leave for her children. Does she want certain people to have certain cookbooks, or are certain foods really meaningful to her? Because throughout her course, end of life is always in the background. Sometimes it becomes the forefront of our conversations and our thoughts in this palliative realm. And so we really want to not ignore it. We want to talk about it and make it as meaningful as possible.
And she ended up, she would bring the cookbooks in a brown paper bag to our meetings because she was giving her
Mhm,
cookbooks away to
mhm.
like us too. So I
Mhm.
felt like we were all part of the same like family. We were part of the same
Mhm.
team.
Yeah, and we saw her for, I think it was about 15 months. Um, and her prognosis was 12 months. And so we really, over that time, got to know her and her husband so well. And I think she developed a lot of trust in us, and we really developed a good relationship with them, which creates so much meaning for our work too. That long-term relationship that as acute care therapist, we don't always get. So that was really, really special for us.
So our next participant, Oscar, he was also a very special one. He is a 73-year-old Native American male. He didn't really have a big medical history. The only main thing was OA, because he spent a lot of time in construction, so he had a lot of aches and pains. He actually had a fairly big family, but his primary caregiver was his daughter, which we'll kind of talk about. He was independent community ambulator. He lived alone because his spouse was in like a memory care unit, or she had her own, health things going on. So she was not in the household. So he pretty much managed all his routines independently. He did have a distant history of falls, but it increased kind of as he went through the treatment. Oscar, he didn't, initially he didn't have a lot of psychosocial needs. He was fairly, content, I think, about what was going on. He always reported his spirits were high. The main thing was his management of his fatigue. He would enjoy going to his grandchildren's baseball games and mowing his lawn and his family's lawn. This was like 7 different lawns he would be mowing. So with the fatigue, the cancer related fatigue, and also, the chemo related fatigue, he wasn't able to do that. So he was kind of like, am I supposed to be this tired? All of this. So just mainly questions about that. But his functional status honestly stayed pretty consistent throughout until he got to end of life. That's when it tanked. He had a fairly consistent care partner. And honestly, I think this highlights like the intervention we were doing with her, because she was not his only child, but she was responsible a lot for his care. She would be the one taking him to appointments, checking in on him. If he was admitted, she would stay with him. So this caused a lot of distress and confusion with her, because she would say, why am I the only one doing this? So it would be a lot of therapeutic listening, therapeutic use of self, kind of, validating her feelings and talking through, okay, so what are some things that we can maybe delegate, or, highlighting his strengths and his functional status, so she would not have to be responsible for that. Just to wrap it up, I think his main highlight was at end of life. Because his disease kind of progressed fairly quickly, where he was good, and then there was a point he wasn't good. He was admitted for a couple days, and then that's when the conversation about hospice kind of came about. And he honestly was fairly content with it. He had lost his brother in the past, and so he was like, I'm ready to go and be with my brother. His daughter had a lot of difficulty around that. So I think as a PAC team, we kind of had to rally around both of them and support his wishes of like, how do you see your end of life? While also supporting her of like, I'm not ready for my father to pass away. There were a lot of things that came up with hospice that I think were related to also his status of being a Native American. He didn't have a high health literacy. So the hospice process was not as smooth. So we definitely had to intervene on that of like, what equipment does he need? What resources? What can they expect in terms of his functional status? But overall, I think that was kind of the highlight of our experience with him during the PACT intervention.
And
All
that
right.
is the short version.
Yes.
You can imagine.
I didn't include this, but we also want to thank Mackenzie Pergolotti.
Yes.
She's the one that connected us with y'all. So shout out to her. She's been a great consultant for the PACT study.
So many resources.
Great. Well, thank you guys. That was amazing. Seriously, so interesting. I love the amount of outcome measures that you guys kind of went through, and I think it really does. And I will also put a shout out for, I'm a big fan of hand grip dynamometry, even though it seems really small. There's a huge ton of predictive validity to it. So I don't think we necessarily do that as much as we could. And I totally agree. Some of our patients just want to squeeze the thing and see if they're better today than they were
love it,
yesterday.
yes.
So I don't know about that. We do have a couple of questions in the chat that I don't know if you have had a chance to take a look at. Ann, do you want to?
I think probably, Chris, why don't we ask Andrea's question, because they sort of answered mine about
Yeah.
inpatient therapists doing outpatient. You spoke to that, which, was really of interest to me because that's a bit overwhelming. But Andrea had some great questions here. The first one is for the outcome measures that you performed, such as the 6-minute walk test and the Berg. Have you been able to compare your patient's baseline to age-matched norms? I guess let's answer that one first.
So unfortunately, we don't have the actual data numbers yet, but just in general from my looking at the norms as I score them, a lot of our participants are really pretty close at baseline, and I think it depends more on when we see them within their chemo cycles rather than how many cycles they've gotten. So if we're seeing them really about a week after their injection chemo, their fatigue is the worst, and that's when they're the furthest away from their norms, and then a lot of them will rebound back up. So we do have an interesting number of people who have these big ebbs and flows in their functional status and energy throughout the whole course, and they really rebound better than I expected them to.
Thank you. Andrea also wanted to know about comorbidity indexes. Did you do anything with that? I think she asked specifically, have you gathered any information regarding comorbidity burden?
The nursing,
They're nursing,
yes.
and they do, and then they also have full access to their medical records and their chart. So a lot of that information is also recorded. We didn't include it in our presentation.
Great, thanks.
Well, if there's no more questions, and in the interest of time, did you have something, Michelle?
Oh, I was just looking over the Q&A questions just to make sure we hit them all.
We just wanted to thank you for this amazing presentation. It will be on our website, so you can refer other people to it, so sort of get people up to speed. And then we wanted to do a little shout out to the next two that we have in the works. One is on reimbursement, specifically for therapy in the hospice space, which is very interesting to all of us, I think, that are here. And the other is an OT who is going to talk about Reiki as an intervention in this space. So lots to come, and we just ask you to ask your colleagues. I love that, interdisciplinary people are working, that we're all working together for this population. So we are just excited to build this bridge and to have rehab and palliative care, combined and not working in parallel, because that's what we're trying to do at Georgetown as well. And it takes sometimes a lot of just grunt, right? So we appreciate your efforts. We appreciate you coming to speak with us. And does anybody have any last questions? Chris, was there any more in there?
Nope, I didn't see any more
Or Jordan?
questions. So thank you, Michelle and Alexis. You guys are amazing, and
You are. Thank
really
you.
inspiring to see some kind of future leaders, especially because Ann and I might have a little bit of gray hair at some point. Or at least we fake
Wow,
having gray hair. So it's great to
Found
see
our
the next
replacements.
generation.
Well, thank you
All
guys
right.
for having us.
Good night, everyone.
Thank
you all.
you.
Bye.